right, good afternoon and welcome. I am Caitlin Quaid, the Program Director for Family Planning Elevated, and I am so delighted to have our program's closest friends and family joining us today for a review and a celebration of our second year expanding contraceptive access in Utah. Yes, we have reached our terrific twos. We joke about FPE being a toddler now, and this is a particularly apt metaphor for me, given that my own human child was born just as FPE launched in 2019. So I have a very handy comparator for all of the developmental milestones we'd expect to see at age 2. And what is life like for FPE right now? Well, we are exploring everything in front of us, but also experimenting with the word no and exploring our boundaries every now and then. We're also walking a bit steadier and covering more ground without tripping quite as much as we did in our first year. And we're starting to vocalize more and finding our voice and using it to share our experiences. And as my little one likes to say, "Aw, cute." So over the next half hour, we will share the ups and downs and sidewayses and diagonals of FPE through 2020. And then let's party. I'll invite you all to come off mute and voice your questions and comments, maybe sing happy birthday, and have an informal discussion with our remaining time. We will be recording today's session and making it available on our website afterwards. And if you're joining us fresh today and want to stroll extra far down memory lane, you can find the recording from our first FPE birthday webinar on our website or YouTube channel. Yes, we do have a YouTube channel. One additional tip to enhance your viewing experience, you'll be hearing from almost our entire team today as alternating speakers. So I'd encourage you to go up to the view dropdown, click on view in your upper right-hand corner and select side-by-side speaker. So this will appear like the very high production affair that it actually is. All right, and next, Maddie. Great. So the driving mission of Family Planning Elevated remains working to ensure that all people have that are all methods at all times in all communities. And through our Contraceptive Access Program, FPE CAP for short, we continue to work toward all people in Utah having access to family planning by providing no-cost contraceptive care for Utahns in the coverage gap. And these are Utahns who are uninsured or underinsured until now have struggled to access contraception because they've been paying out of pocket. All methods, we know it can be hard to find a method that works just right for you, and that's why we work with health centers to offer all FDA-approved methods to patients. Yes, even the priciest ones, and yes, even the ones in lower demand. Every method is an underdog in its own way, and we provide training and resources to champion each one of them. At all times means even in a global pandemic, our clinics are considering FP visits essential services and providing that care to their patients. And in all communities, this means not just expanding access here in the Salt Lake Valley, but in an increasing number of communities around our beautiful state, and working to make sure that the voices of these communities are heard through the Utah Reproductive Justice Community Advisory Board. This, in a nutshell, is what FPE does and what our entire team will continue to work toward in the final year of implementation. And speaking of our team, Sarah has a few updates for us.
Yes, thank you, Caitlin. As Caitlin just mentioned there, you're going to hear from our whole team during the course of this presentation. And we have had a few staffing changes over the last year. For instance, you may not recognize my name. I'm Sarah Elliott, and I'm the operations manager for the Family Planning Division at the university. And I also help with finances and operations for Family Planning Elevated. And I actually started my first week last year during the first FPE webinar. So this is great to be able to be a part of this second one. One of the largest changes that occurred over the last year is our fearless director, Kyle Myers, left the team near the end of 2020 as they shifted full time to follow their passion of gender creative education, including the release of their first book. We're so proud of their work and feel so fortunate to have had their expertise and leadership shape FPE into what it is today. In order to fill those very large shoes, the very capable Caitlin Quaid has stepped into the role of FPE director. Caitlin acted as the program manager in concert with Kyle previously, and the program is in excellent hands with her leadership, knowledge, and passion for this work. Jamie Bade, who has worked with FPE part-time as our process evaluation guru, has also now joined the FPE team full-time and taken on the program manager role in addition to her evaluation duties. Rachel Hemmert has joined the FPE team with a focus on data linkage and statewide evaluation. And finally, Erica Torres has joined the team as our new project facilitator. So we look forward to continuing this work with this amazingly talented team as we head into 2021. But before we look forward, let's take a look back at the challenges and accomplishments that have happened in 2020.
It's hard to think about those first few months of 2020 without also considering, with some measure of dread, the COVID-19 pandemic about to sweep through our homes, our clinics, our communities, and the world. But thinking back to January 2020 and our last birthday party webinar in February of 2020, it was a time of relative optimism in the FPE world. We had a beautiful heap of lessons learned from policy shifts and program changes in 2019, and things were starting to hum along with our 14 FPE CAP clinics. 2020 was going to be our year, and that optimism extended to our hopes for 2020's legislative session.
So given that Utah has a short 45-day legislative session, most of the 2020 session was pre-pandemic and proved to be a very engaged year for FPE. Leading up to the legislative session, we partnered with State Innovation Exchange and Scholar Strategy Network to host a pre-legislation, pro-family, pro-health meeting of the minds and in-person dinner. Remember those? This event was successful in connecting over 20 researchers to 5 policymakers on family planning issues, as well as broader reproductive justice related policy. During 2020, we participated in coalition building and held weekly office hours at the Capitol and became a resource for progressive pro-family policy efforts. We were also very active in coordinating provider expert testimony to oppose harmful anti-abortion legislation, specifically bills related to fetal tissue disposal, mandatory ultrasound, and a statewide abortion ban if Roe versus Wade was overturned. While the fetal tissue and trigger ban were ultimately passed, the mandatory ultrasound bill died in the final hours of the session when every woman in the Utah Senate walked out in protest. So we actively supported some progressive policy, including expanded Medicaid family planning coverage to 250% federal poverty level, using the experiences of FPE. So this received support, but ultimately did not pass due to state appropriations. Our efforts also supported the removal of parental consent language to allow for confidential contraceptive care for minors and expanded coverage of infertility treatment, both presenting an opportunity for relationship building and expanding the conversation around full spectrum and the need of family planning policy. You can read more about FPE and policy with our pre and post session briefs. We also engaged in administrative advocacy to support the return of Title X funding to the state and joined in conversation with the Utah Board of Pharmacy to expand the role that in-clinic pharmacies can play to expand point of care access. And you'll hear a bit more about that later on. All this is to say that FPE has both stuck to our mission of expanding access across the state and been very responsive to the issues as they arise.
In January, full Medicaid expansion had finally gone into effect, making thousands more Utahns eligible for healthcare coverage, including contraceptives. With Medicaid covering a greater share, FPE CAP patient eligibility also shifted to start where Medicaid stops. This change, in turn, allowed us to consider who else could be served through the program. And on March 1st, FPE CAP expanded coverage to adolescents under 18 for the first time. After many iterations of defining the contraceptive coverage gap through FPE, the eligibility guidelines we set last March are still in place, which has made things a bit easier for our clinics. We also introduced the FPE CAP exception form, which allows clinics to make a determination of FPE CAP eligibility on a case-by-case basis for a patient who doesn't fit the strict eligibility guidelines. The exception form is our safety net for our safety net. We have only seen the form used a handful of times. For example, the exception was used to provide care to a patient over the age of 50. However, simply knowing the option exists has given providers and clinic staff a greater degree of confidence and control in implementing the program.
March brought stay-at-home orders and the first wave of large-scale shutdowns, as you might remember, marking the end of normal life as most of us had known it. In Salt Lake City, these changes were also accompanied by a 5.7 magnitude earthquake on March 18th, which added a particularly apocalyptic flavor to the general sense of unease that most of us were feeling. With elective procedures postponed and new hospital visitor policies quickly enacted, we worried that FPE CAP clinics might close the proverbial door to their contraceptive patients. We were wrong. Our clinics immediately sprang to action by offering telehealth contraceptive appointments. One clinic even reported that they were calling any patient who was late to pick up their oral contraceptive pills or who needed their next depot shot. Of course, we did see a decline in contraceptive services at our clinics. As a proportion of total services provided to women of reproductive age, contraceptive services were down 24% compared to March 2019 at our FPE CAP clinics. As spring bore on, service delivery trends began to normalize. By June of 2020, contraceptive service provision was nearly 10% higher than it had been the previous year. Clearly, our community values contraceptive services as an essential service.
At the beginning of the pandemic, clinics were rallying to maintain services while keeping their staff safe. Some clinics wondered if they could stay afloat while others struggled with staffing challenges, either with team members out sick or in the case of 2 county health departments in FP focused on contact tracing. Our clinic system in Southern Utah was slated to begin FPE CAP in March, but the commotion of the times proved too great and they opted to focus on their existing services rather than take on a new program like FPE. Ultimately, Cohort 3 launched in March and April with 4 clinics, expanding FPE sites to Carbon County, Utah County, and Ogden, and bringing our clinic grand total to 19.
As the realities of COVID-19 and stay-at-home orders started to hit Utah, we recognized that the pandemic would likely impact the types of contraceptive care that people would be able to receive. So we assembled an advisory board of academics, policymakers, providers, pharmacists, and other stakeholders over the course of the spring to discuss how to support ongoing access to contraception during pandemic times. The advisory board developed both a fact sheet to help contraceptive users identify ways to maintain their access during the pandemic, and a fact sheet for providers with recommendations on how to continue to prioritize contraceptive care during this tough time.
Due to the pandemic and the racial reckonings occurring this past year, our Reproductive Justice Community Advisory Board members have been working tirelessly to ensure the voices in their communities are being heard and their needs are being met. During 2020, FPE acted in the background, providing direct support to individual members to continue their work as doulas, healers, educators, and advocates for reproductive and racial justice. One of our board members, Ashley Finley, was recently recognized as one of Slug Magazine's community leaders for her work in birth keeping. We are looking forward to continuing to assist the ongoing work of RJCAB in 2021.
With public health safety measures in place, we had to pivot from our original plan to bring 200 plus people together in June in person for 2 spectacular days of contraceptive education, hands-on training, and breathing on each other. We made the difficult but necessary decision to cancel the conference we'd spent nearly a year planning. The handful of clinic-level trainings on IUDs and implants scheduled for that spring were similarly put on hold as we and Merck assessed the risk of in-person gatherings. Fortunately, we were able to reschedule the majority of these small group sessions for later in the year. In the meantime, we shifted strategy and in June launched the Contraceptive Education Series, which was a monthly webinar for FPE CAP members, staff, and the greater learning community on a variety of contraceptive topics. Many of them were requested by our clinics. In 2020, we covered barrier methods, adolescent care, emergency contraception, quick start contraception, FABM and knowledge-based methods, contraceptive coercion, and integrating PrEP.
And then the dog days of summer came along, a time for relaxing and kicking back and, adding 9 new health centers to FPE CAP. On August 1st, we welcomed 6 additional clinics from Midtown Community Health Centers, 2 additional clinics from CHC Inc., and 1 additional clinic from Planned Parenthood. These clinics have helped extend FPE's reach to additional communities, from Logan in the north to St. George, way down south, and in different clinic settings, including Midtown Children's Clinic and the Hope Homeless Center. While the pandemic unfortunately prevented us from visiting each new clinic in person, we met clinic teams online, shipped methods out to each site, and answered questions along the way.
August was also a milestone month for our primary outcome evaluation. So as you may or may not know, we are evaluating contraceptive service provision before, during, and after FPE at our intervention sites. But part of this evaluation involves recruiting control sites that look similar to our intervention sites, but don't implement FPE. So in August, we recruited the last 2 control sites we needed for our program, which was a huge win, but also sadly lost an existing control site as it closed forever due to COVID. Ultimately, our control clinics are providing us their data really out of the goodness of their hearts, and we deeply appreciate it.
August brought yet another important FPE milestone. One of our sites provided a client with a Kaya diaphragm. Hooray! This milestone was met with considerable excitement by our FPE team. Our celebration was due in large part to just how much work the FPE team and our clinic providers had put into ensuring that each clinic was stocked with barrier methods and that each site had providers comfortable in counseling on those methods. We worked to remove barriers to accessing lower demand methods by stocking every clinic with diaphragms, cervical caps, sponges, and spermicides, as well as internal and external condoms and natural cycle starter kit. We also provided interactive webinars on barrier methods and knowledge-based methods, as well as in-person training on counseling for barrier methods. Finally, we provided opportunities to practice counseling on lower demand methods during our simulation trainings with FPE CAP clinics.
By late September, a project we'd been working on for almost a year was finally coming to fruition. If you tuned in last year, you might recall that the Utah Board of Pharmacy approved a rule change in late 2019, which allows clinicians to become licensed to dispense hormonal contraceptives in their clinics, eliminating the need for patients to make an extra trip to the pharmacy. But how does a clinic get started with this? Through the spring and early summer, we compiled a how-to manual for FPE CAP clinics on contraceptive dispensing, drawing on that Pharmacy Practice Act rule, inspection forms, and expertise from colleagues at the university's College of Pharmacy and the Utah Board of Pharmacy. With the process spelled out, 3 pioneering FPE CAP clinics took the first step to becoming dispensing medical practitioner clinics by applying for and receiving conditional licensure. They will undergo inspection in the coming months to become fully fledged dispensing clinics.
While the summers of the past were usually filled with travel and weekend barbecues, the summer of 2020 was a bit different. Most of us were settling into our work from home lifestyles, complete with the occasional pantsless Zoom meeting. Perhaps we should have seen it coming then that Labor Day, a holiday that generally marks the return to calm after a frenzied summer, might also have a new look this year. On Tuesday, September 8th, a powerful windstorm hit the Wasatch Front, ripping out trees and power lines and leaving many, including most of our team, without power for up to a week. Once the dust settled, both figuratively and quite literally, we were excited to get back to work in our clinics.
2020 was our year for first piloting and then expanding the use of simulation training with our FPE CAP clinics. The idea to conduct family planning simulations was born in 2019 when the LIFT Simulation Design Lab, located at the College of Nursing, hosted a series of simulation trainings to prepare home birth midwives, EMS, and hospital providers to successfully stabilize and transfer patients who are having a postpartum hemorrhage during a home birth. 2 of the FPE team members were patient actors for those hemorrhage simulations. As the FPE team worked together with the Lift Lab on those simulations, we realized that simulation had not, to our knowledge, previously been used to understand family planning care on a clinic level. At the time, we were looking for a way to see how the FPE CAP program was being implemented in each of our unique clinics. We realized family planning simulations would allow us to see what a patient visit actually looks like in each of the FPE CAP clinics, while also providing those clinics with some technical support and training. With the green light from our donors, we partnered with the Lift Lab and designed 2 simulation scenarios to conduct with FPE CAP clinics. Our first scenario encompasses the entire patient visit, from check-in and screening the patient for program eligibility, to taking vitals and conversation with the medical assistant, and finally to contraceptive counseling with the provider. The second simulation scenario involves a patient who schedules an appointment because she is unhappy with her method and is ultimately interested in switching to a lower demand method. After designing these 2 scenarios, we hosted simulation trainings with our clinic sites around the state, where they were able to participate in the scenarios with their staff and in their own clinics. We conducted simulation trainings and structured debriefs with 10 of our clinics in 2020 and plan to conduct 6 additional simulation trainings in 2021. In my admittedly biased opinion, these simulations have exceeded our expectations. Because of these simulations, we have been able to see in real time both clinic successes and struggles, as well as identify specific areas FPE could provide support. Some of our takeaways have been, first, while most providers understand and agree that clients should be presented with all contraceptive methods, in practice, some providers experience distress when their clients want to switch from a method which is more effective at preventing pregnancy to one that is less effective at preventing pregnancy. Through simulation, we created opportunities for providers to counsel on a range of methods and then share their counseling approaches and questions during the debrief. We have been able to have rich discussions around why clients might select a particular method and brainstorm with providers affirming productive ways to counsel on some of those lower demand methods. We have facilitated group conversation on what it means to provide patient-centered counseling, and providers have shared ways they identify and mitigate personal biases towards particular methods. Simulation has also helped improve our programmatic operations. Simulated patient visits have allowed us to view some of the implementation differences across sites and identify best practices. We have used some of the clinic challenges we identified during simulations to develop novel ways to structure our program. For example, we learned during one of our simulations that the site was struggling with how to bill the complexity of the contraceptive visit. They wondered if a patient has many health problems which weren't strictly related to contraception, would that still be considered a complex visit? As a result of our discussion around this and recognizing the same issue at a few other sites, FPE revised our counseling reimbursement to clinics to be a flat fee for all contraceptive counseling. Finally, we learned that part of the magic of simulation is that it allows participants to self-identify areas where they may need more education or training. Rather than having us recommend or offer trainings on fertility awareness-based methods or optimizing clinic workflow, after simulation, the participants have been motivated and eager to receive trainings in the areas they have identified as needing support. Simulation really spurs engagement around subject material in a way that we haven't seen in traditional didactic sessions.
Throughout the year, FPE worked with our partnered communications agency to develop and launch our new website, myfpe.org, and our digital media campaign. The media campaign had a threefold mission: advertise newly expanded Medicaid eligibility, educate the public on topics related to fertility and contraception, and market no-cost contraceptive services available at FPE CAP clinic locations. The communications agency created an array of digital and social media advertisements in both English and Spanish. However, due to the political climate, social media platforms had tightened restrictions on what ads could be run on their sites. FPE's ads were deemed a social issue by Facebook, which in turn placed our ads in the same high alert category as political discourse. Facebook repeatedly blocked FPE's ads on social media, and our communications agency shared that in their 10 years of experience, they had never previously encountered such restrictive social media policies. Ultimately, we were unable to bypass the stringent social media restrictions imposed on our advertisements, and the media agency refocused efforts to sharing the FPE campaign through digital ads and pay per click. As a team, we're pivoting to create a customized media campaign for each of the FPE CAP clinics who can accommodate the influx of new patients. Until the social media platform's restrictions have relaxed, our media campaign will use more traditional forms of media, such as newspapers, magazines, and radio to advertise services. Our partner clinics are each unique and have different capacities, and we are working to be responsive to each of the clinic's individual needs and tailor a media campaign that targets the communities each clinic serves.
As FPE CAP rolled out to our partners across the state, we realized that there were some clinics who could benefit from the program, but who didn't necessarily meet the eligibility criteria for FPE CAP. Thus, the FPE Affiliate Program was born. The Affiliate Program allows us to tailor our support for individual clinics while still holding to our mission of supporting clinics and offering clients all methods. We are currently working with 3 FPE affiliate sites. The first is the Campus Contraceptive Initiative, which provides free contraceptive services to students at the University of Utah through a mix of telehealth appointments for counseling and prescription methods and in-clinic appointments for device insertions and removals. The second is Planned Parenthood's Metro Clinic. The program at PP Metro allows FPE eligible clients who receive abortion care to then receive free contraceptive care anytime within the year following their procedure at any Planned Parenthood clinic in the state. Last but not least, we're currently onboarding Moab Regional Hospital as an affiliate site and supporting their contraceptive offering in an under-resourced corner of the state. We plan to enroll at least 1 additional affiliate site this year. Each affiliate site will receive 1 year of support to include reimbursement for methods, as well as technical offerings and on-site trainings. We look forward to gaining valuable insight into these clinics that serve unique populations and strengthening and expanding FPE partnerships through this program.
So here we are back in the 2021 general legislative session. But during the interim, we continue to engage in policy work and education and relationship building. So we're yet again, while it looks a little bit different this year and much more online than it was last year, we're again coordinating efforts with community and coalition members to provide evidence-based opposition to increasing abortion restrictions, as well as support for progressive, expansive policies. We're working with national partners to better support those progressive policies as well. So one great example is the Senate Bill 128, which is the Family Planning Service Amendments, which if passed if passed and funded, would expand family planning Medicaid coverage for folks falling in the between 138 and 250% federal poverty. The need and impact of this expansion is what FPE has really been demonstrating with our partner FPE CAP clinics. Passage in this bill would be one step in creating a more sustainable solution for the state. Just this past Friday, this bill passed favorably out of the Health and Human Services Senate Committee, in no small part due to beautiful expert testimony by our FPE CAP partner and provider, Danelle Pendergrass. We are also very excited to see this moving forward. We're also working to support contraceptive equity broadly. And some of the 2021 policy efforts include a Contraceptive Equity Act, which fills in contraceptive coverage for any public or private insurance plans that are currently grandfathered in to not having comprehensive coverage or exempt from that coverage. We're also providing support for a bill that would allow for women in the carceral system to continue their contraceptive method as essential medication. So these are just some examples of things that we're engaged in right now. So I encourage you all to stay tuned for our post-session brief because, as you know, things happen quickly.
When we enrolled clinics in our FPE CAP program, we committed to partnering with them for 2 years. And while 2 years might have sounded like a long time at the outset, now that we're reaching the end of those 2 years with our first round of clinics, it feels like no time at all. The first cohort of FPE CAP clinics will graduate from our program in May of this year. We're calling this a graduation rather than ending the program because our goal is to continue the hopefully mutually beneficial partnerships with each of the clinics. We also hope that the elements of the trainings and technical support they receive from FPE will continue to benefit the clinics and their clients. We are currently mapping out the details of the graduation plan for clinics. The first of these components is a LARC removal fund. So individuals who received an IUD or implant through FPE will be able to have the device removed free of charge for at least 1 year after the clinic graduates. We also plan to provide technical support on contraceptive cases and clinical questions via regular Project ECHO offerings, invitations to attend regional contraceptive education and training conferences, monthly emails about technical offerings and opportunities, and clinical support from now regional FP trained proctors and additional opportunities for simulation trainings, because that's what we do.
Although we were unable to host our annual contraceptive education and training conference in 2020, preparations for regional CETCs are in full swing. This year, we hope to host 3 regional conferences aiming at reaching areas where contraceptive deserts exist. In addition to these regional conferences, we hope to host a Train the Trainer with a few of our FPE CAP site providers. We continue to be optimistic that 2022 will be the year where we can all gather again for a larger CETC.
2020 also saw some expanded conversations with other contraceptive initiatives as we participated in larger meetings with both Converge and EverThrive, and as well as SICA and ASTHO, in discussions about how to measure and assess the success of initiatives like ours. We are looking forward to participating in 2021 with SICA and ASTHO in the development of guidelines and evidence around what a successful contraceptive initiative should look like. And we're excited to learn more from them as well as our sister initiative sites in other states.
Our interest in expanding access to comprehensive family planning is also broadening within our division. In 2020, we received a planning grant to create an official Center for Family Planning in the Intermountain West. This support has allowed us to conduct a statewide landscape analysis of family planning barriers and facilitators throughout Utah. We have conducted community focus groups and in-depth interviews with key stakeholders from the community and healthcare fields on both sides of the political spectrum. We are so excited to translate this wealth of information into specific projects that will be directly responsive to the needs of our state.
As if all this wasn't enough, our division has also been working on other projects outside of FPE. Our medical director, Dr. Dave Turok, recently concluded a randomized control trial comparing use of the levonorgestrel IUD to the copper IUD as emergency contraception. Results suggest that both are more effective at preventing pregnancy than Plan B, and our primary outcome paper was just published in the New England Journal of Medicine. In the spirit of expanding access, we plan to work with FPE CAP clinics this year to implement our findings that IUDs should be offered to patients who come in seeking EC. And for those of you interested in diving further into the nitty-gritty about what we're doing, we also published 2 papers this past year describing different parts of FPE's evaluation. One outlining our primary outcome approach, and one outlining how we are conducting our process evaluation. Stay tuned for more of FPE's evaluation later this year.
Wonderful. And that really concludes our trip down memory lane and our peek towards what's ahead for FPE in 2021 and beyond. And now it's time to get the party started. And I have been advised by my colleagues to not force everybody to sing happy birthday with some somewhat asynchronous tunings in. But we do want to hear from you. So raise your hand, take yourself off mute, or if you're not feeling quite so bold on a Monday, type your questions into chat, and we're happy to talk more about FPE.
I have a question about becoming a pharmacy to distribute contraception. And this is Jen from Summit County Health Department.
Great, Jen, shoot.
Well, I would like to know, I would like Summit County to become a pharmacy that can distribute oral contraception. How do we go about doing that?
Yeah, so the first step is I will provide the how-to manual that we put together, which goes over sort of the background of this rule change and then how to actually implement it in your clinic. So what are the record keeping requirements, labeling and dispensing, all of those great details that the Department of Occupational and Professional Licensing will be looking for when they come to the clinic. And really then just looking through what those requirements are and seeing if each of your clinics is in a position to put that into practice. So it might mean for one of our clinics, they had to purchase a new locked cupboard because the contraceptives would need to be locked away. For others, it meant figuring out how to have their EHR system print out the labels needed for to attach to the contraceptives. So walking through each of those requirements and then applying. And once clinics apply, they if everything is looking good, they'll receive a conditional license and then receive an inspection visit from DOPL, usually within those first few months. And if the clinic passes inspection, then you are good to dispense for 2 years.
I'm interested to know the experience of the clinics that have been working on it. What have their stumbling blocks been, or do they have any advice?
Yeah, so we have 2 clinics who have not yet received their in-clinic visits, their inspections, but again, had just been working in these last few months in getting that conditional license and getting their clinics up and ready. I don't want to put Danelle on the spot. I know, Danelle, you've been working to implement this at Eastern Utah. If you have any words of wisdom to share with
Sure, absolutely. So this manual that was put together is like the ultimate. It is so easy to follow step by step in what you need to do. So what we kind of did is we kind of walked around our clinic and we're like, oh, we're definitely going to need to get label makers and figure out how to print that out and just find like our little weak spots. And really, there weren't a whole lot. So we just used that manual. It was very simple. The application process was very simple. And then all I can say is be ready, because they were more than eager to come down and do an inspection. So just kind of have everything in order. It's not a huge undertaking, and those seeking contraceptives are going to be so grateful for it. So not a big process. If you need any help or moral support, I'm happy to help you there.
Thank you so much, Danelle, for sharing your experience. We've also worked to really keep the Utah Board of Pharmacy up to date on what we're doing so that they know that there will be clinics applying for these licenses. And I presented to their board just a few months ago and received really great feedback and support, including from their inspectors. And so now we have a direct line to some of the inspectors who will be coming out to clinics just to ask questions in advance. You know, we haven't seen this implemented in the state in this way before. So we are paving the way.
I see Mark Hathaway has a question, so feel free to unmute yourself, Mark, and ask.
Thank you so much. Congratulations and happy birthday. I've been a big fan of your program for many years, so I'm thrilled that you guys are doing such great stuff. And it's fantastic to look at your program in terms of providing services, but also thinking about the long-term legislative nudges and changes and advocacy work. I have a question, a couple of questions. One regarding the walkout that you mentioned of the ultrasound mandate. I'm just curious if that's perhaps going to be coming back to a proposal to the legislature there, as well as the Title X program, and now perhaps clinics in Utah being able to apply, or Planned Parenthood for that matter, apply again for Title X funding. Thanks very much.
Yeah, thank you for that question, and thank you for all the work that you do as well. You know, with the mandatory ultrasound, we are seeing an abortion amendment this session that is not exactly the same, because there was such a strong reaction by senators, specifically the female women senators that chose to walk out. And one of those women is now the lieutenant governor. So I think that there was enough halting, you know, there was enough pushback last year that the legislator who ran that bill is not planning on running the exact same thing. That being said, he might have been emboldened, and he's running an equally restrictive, or more restrictive and punitive bill this session that we're keeping a really close eye on, and having a lot more of these conversations before it's even out of committee. So, you know, hoping that it doesn't actually come to fruition. But the hope is that there was some lessons learned last year, and that type of legislation will be either, you know, stalled or vetoed, because the public opinion is that Utah has enough abortion restrictions. But those conversations and willingness to have kind of those more nuanced conversations has proven to be a good, at least progress. And then in terms of Title X, because of the language in Utah code about not providing confidential care to minors that require parental consent, there's actually legislation that is being run that says that can stay true in the code, except for places that receive federal funding through Medicaid or Title X. So they would be able to not have that same restriction, which would allow for Title X to come back to some of the state entities that are not as that currently haven't been doing family planning care. So some of the county health or through the health department. I do believe that with the new federal administration, we will see a reapplication for Planned Parenthood to apply for Title X funds, or whatever that looks like when that becomes available. So, and Planned Parenthood has been a really incredible partner, both as part of the kind of reproductive coalition, reproductive rights and justice coalition, as well as with research and clinical care. So a big shout out to them as well.
Great. And Jess, while you're there, we did have one question. What advice would you have for others working on contraceptive policy in red states?
Yeah, I think one of the things that we've learned is a lot of relationship building is really important, and that trust building, both with other advocacy organizations that maybe have, you know, their own kind of unique populations or perspectives that they're working from, to see where your policies overlap, places that, you know, you can support them and they can support you, and it becomes more of a you know, a group effort. I think that's a really important piece, both so that you don't feel like you're alone in banging your head against the brick wall that is working on progressive policy in red states, but also to get things done. And then the other piece is really just being okay with some incremental progress. It's really hard. Like, they're really exciting wins that happen, but when they do happen, but frequently it's just about having a conversation and having someone who maybe wasn't willing to listen to you last year kind of perk up and ask for research or ask for information. And so I think that's a big part of it as well.
Great. And we did have a question about evaluation. Can you talk a little bit more about what your outcome evaluation is measuring? What does success look like? And what are some of your primary data sources?
I can take that one, and then maybe Alex can fill in. So for our primary outcome evaluation, we are collecting service delivery data from the electronic health records of our different sites, our intervention sites, our FP-CAP sites, as well as our control clinics. And we're looking at really level and trend changes over time. So we collected data from our clinics starting in January of 2018, which for most sites is a year to 2 years prior to their start of FPE. And then we're going to collect data from these same sites for a year after the FPE implementation ends. And the reason that we're doing this, looking at contraceptive service provision over time, is really because, as we've seen in both of our webinars, when you have these large changes in policies or you have Medicaid kind of stepping in and stepping out and shifting, it can be hard to attribute actual change from our intervention versus all of the environmental factors. So doing this comparative interrupted time series analysis that looks at these changes over time can really help us dial in to say, this is more due to us, and these other changes and shifts were due to these policy changes or these environmental factors. Alex, I don't know if you have anything else you want to add to that?
Yeah, sure. I think just about the data sources themselves. As Rebecca said, we are collecting service delivery data from our clinics, so straight out of the EHR, and we're collecting data on all visits among women between 18 or now between 12 to 50. We changed the age parameters in March of 2020, as we mentioned earlier. And so we collect all ICD codes and CPT codes to get at both the diagnostic information for the visit and whatever procedural codes or services or methods were provided and billed for. And that way we can look at any visit that denotes a contraceptive service or discussion. And we also are collecting demographic information as well, which becomes a little tricky with some of our clinics that don't necessarily collect all of the same variables across the board. So using some proxy information as needed.
Thank you both. And an opportunity for more questions if we have folks.
Hi, my name is Rachel Endo, and I work with an organization in Chattanooga, Tennessee. So I was excited to hear you guys address a question about red states. A question that I have is, do you guys work with clinics in the more rural areas of Utah? And if you do, what barriers have you found? Or what success stories do you have in working with these clinics to get them on board with using birth control methods?
That's such a great question, Rachel. And I am so happy to have Danelle Pendergrass here from Eastern Utah Women's Health, which is indeed in a rural area in Price, Utah. Danelle, do you have any words of wisdom to share from your perspective of getting started in FPE and implementing the program there?
So this is exactly what our rural community needed, because as you know, living in rural areas, more people, there are more Medicaid beneficiaries per capita there. And especially with Title X not being available, this left a huge gap in healthcare. So getting up and running was absolutely, it was not difficult. The one thing that was learning how to collect all the data that was needed. And that was the only real big learning curve. And we're so grateful we've had that data, because now we can use it in everything. So that was the big win for our clinic. And then just knowing that you could offer any form of birth control that somebody needed instead of certain ones, or I'm sorry, you can't afford that, or this is going to cost too much, was phenomenal. We actually learned how to get people signed up for Medicaid since it increased to 135% the poverty level. And it was a great learning experience. My team was all on board because we could see the difference that we would make in our rural community. So I would just suggest, if you're going to do this in your rural areas, really get the team together and really show them what they can do for the women and families in the community. It's been a joy, and people always know they can come to us and get the care that they need, and we don't have to turn anyone away. So, and I would be happy if you want to talk offline or whatever to more about rural communities.
Thank you so much, Danelle. I know from a training perspective too, we did hear from some providers saying, being in a rural area makes it a little bit more difficult to offer methods, the full range of methods, when you're the lone wolf for providing an IUD or an implant, and knowing that you don't have somebody down the hall necessarily to reach out to if you have questions. And that was really an aim of ours, to be able to provide that consistent technical support through on-site training. And then Jessica Lewis-Caprell has been phenomenal in going out and doing one-on-one proctoring visits with clinicians so that they can gain comfort in providing all the methods.
And then it looks like Mark had a question about male engagement and our success with male engagement.
Yeah, this is Mark. You don't need to answer that question. It's complicated, but I am kind of curious if you have any quick thoughts about, how you've engaged men, if at all, and how that's worked out.
Yeah, I will say being able to include vasectomy as one of our covered contraceptive services was a huge shift for the program. We had been hearing from our clinics in the months leading up to it, what are we doing for the full family, and why is this just a burden for women? And they're asking if their husbands can come in instead. So that was a really a big turning point for us as a program, and has really changed, who our audience and who we're able to serve. As far as media campaign and engagement, we are not looking specifically at those demographics, as far as I know, through our partnered media agency.
But part of our education media campaign will include some education around male fertility as well as female fertility. So there should be a little bit there for folks who might engage in that way.
All right. Seems, we've got one. What is the 5-year plan for Family Planning Elevated? Oh man, Gabby, that's a great question. So implementation for Family Planning Elevated will run for an additional year, and that's to give our cohort 3, our final cohort, their full 2 years in the program, and our affiliate sites 1 year in the program. And after that time, we'll continue to receive monthly service delivery data from clinics, so that Rebecca and Alex can crunch those numbers and see what sort of impact FPE has had. And then, as we mentioned, we're really hoping to see Family Planning Elevated grow into, hopefully increased funding for contraceptives at the policy level, but also new initiatives that we may take on through the Ascent Center. And I welcome any of my colleagues to throw in more details about what our collective 5-year plan could look like. And Jennifer asks, where can I find a list of FPE clinics? That would be on our website at myfpe.org. There we go. Wonderful. And last but not least, before we leave, just a very hearty thank you to our donors. The Arnold Ventures, a small anonymous foundation, the Dr. Ezekiel R. and Edna Wattis Dumke Foundation, and then our pharmaceutical contributors, Cooper Surgical, Merck, and Bayer, as well as community donors. We would not have been able to do this program without you, and you really have helped us breathe life into FPE. All right. And with that, I welcome you. A lovely rest of your day. Please take good care of yourselves, and we'll see you next time. Thank you.